So with that, I am today's presenter, so I want to just make sure that everybody can see that. Can you just, Brenda, just tell me yes or no?
Yes.
Okay, great, thanks. So today I thought it would be appropriate that we start at the beginning of a new year, talking about what's exciting in delaying the progression of kidney disease, what's new and what's coming. And to that end, I start with some disclosures and perspectives. So many of you know that I'm a clinician, administrator, researcher, and educator, and I do hold a number of peer review grant funds, have research support, and have the privilege of being on a number of steering committee and data safety monitoring boards for some large local as well as international clinical trials. And I'm also a scientific advisor, as you see listed here. All of these, I think, give me perspective, and I hope I can share those perspectives with you as my colleagues and people, healthcare professionals around the province, country, and internationally. So my goals for this presentation are to ensure that all of us have an understanding of really what chronic kidney disease is as a global public health burden and its implications. But mostly I'm going to talk about new tools and approaches to diagnosis and the new treatments, many of which are approved and some of which are under study, which I think makes kidney disease right now a really amazing space to be in. And as the co-chair of the KDIGO updated guidelines, I'm going to give you a little bit of an overview of what that says. Some of you have seen that before, but hopefully that will help contextualize all of this. But mostly what I'd like to do is stimulate discussion either at this call or this meeting, but also potentially after you reflect and go away, and as you see patients and talk amongst yourselves, that this will continue to excite you and others about how great it is to be in the nephrology space right now. So many of you may have seen this slide. This is from a Kidney International paper, but about 850 million people are living with chronic kidney disease, and it's more prevalent in people with diabetes, racial minorities, the elderly, women, and an individual with hypertension. But alarmingly, it's increasing at a rate, and the death rate, it will be the fifth leading cause of death in 2040 worldwide. And it's a large burden, not just economically for places like us with high income countries, but also in low and middle income countries. And it's among the top 10 causes of death in these three countries, which Singapore, Greece, and Israel, which just gives you a feel for how, and it's number 2 in Mexico, just as a by the way. And it affects, as I said, 1 in 10 adults. That's about 850 million people. Almost half of people with type 2 diabetes have some degree of kidney dysfunction, and 20% of people also have heart failure. Sadly, about 5 to 10 million people with chronic kidney disease die each year related to cardiovascular disease. And it's the most common reason for progression to kidney failure, and diabetes is the leading cause of kidney failure. That is the need for replacement therapy. But I think importantly, as we sit in a privileged country like Canada, it has a lot of high income, the mean annual total cost expenditures of people with kidney disease before dialysis is between $5,000 and $55,000 US, and that increases to between $20,000 and $100,000 if you actually need kidney replacement therapy, be that transplantation or dialysis. And so it's important for us to remember that it's common, it's harmful to people, societies, and healthcare systems, but it's also becoming more and more treatable. It's linked to a number of non-communicable diseases. But as we look around the world, there's huge variability in the approaches, resources, and policies, not only between countries and regions, but even within them. And in our own country, in Canada, we know that kidney disease has different resource allocations in the different provinces. We know that both acute and chronic kidney diseases, and I put that plurally, contribute to this burden, and that we as clinicians and healthcare providers, researchers, and the systems that we work in really have a big role to play in prevention and control, in making sure that we integrate as much as possible with national and international non-communicable disease management strategies, ultimately to optimize patient outcomes. And some of the clinical problems that people face is the access to care, and whether that's access to prevention, delay of progression, or renal replacement therapies. This very sobering slide shows us that between 2010 and 2030, there's been a huge increase in number of people who have or will receive kidney replacement therapy. But there's also a huge burden of people who need it, who will not receive it for a number of reasons. And whilst that is way more prevalent in low and middle income countries, I'll point out that even in high income countries, about 40% of people will not receive care for kidney failure for a variety of reasons, not of their own choice. And sometimes that's about resources, geography, or access to care. And we do know, but it's sometimes nice to articulate it, that identifying high-risk early disease people is less costly than preventing progression of both kidney disease or cardiovascular disease. That dialysis is the most expensive, as I said a few slides ago, and transplantation offers certainly a cost-effective and excellent alternative way, but still is expensive to communities, families, and the healthcare system. And if you think about how we can promote kidney health, one is by having awareness of the disease and understanding the totality of the burden. And that includes defining the problem and identifying causes and risk factors, which I'll come to. But importantly, it's our job to generate solutions, develop and test interventions, and importantly, to implement them. And then see if they're working in practice. And if they are or they aren't, or in certain people they are or they aren't, then how do we redefine the problem and reevaluate what we're doing? And I think this is important as a collective and something that we need to look at doing. But as I said at the beginning, it's a very exciting time in the kidney space. We've got huge improvements in tools for diagnosis and risk stratification that are in keeping with the whole movement of precision medicine. I'm going to show you some of the current evidence that to delay and prevent kidney disease, and that's growing, and that there are new paradigms of care and implementation science which we can take advantage of. So we've learned the value of consistent definitions, and whilst a lot of people roll their eyes at yet another set of nomenclature, I think it's really important that we have these names so that we can talk to people, patients, policymakers, and importantly, across clinical studies, these consistent definitions. We've learned how to collaborate internationally, and proudly, I think kidney disease is now very good at doing international trials. And we've improved our research paradigms in terms of novel study designs, ultimately to show improved outcomes for patients. Although, as I said, uptake and implementation is not yet where we're going. So we have a number of tools to improve diagnosis, and I'm going to go through some of this, and our understanding of genetics and the genetic implications for disease progression and potentially treatments is growing. We have validated improved equations to estimate GFR, and again, I'll show you why that might be important. And we have new tools to assess the other components, because GFR, glomerular filtration rate, is just one of the multiple components of kidney disease, and that includes tubular function, the concept of renal reserve, and I'll show you some new imaging techniques. We have validated risk predictions for not just progression of kidney disease, but now cardiovascular events and other things, and new therapies, which is what I'm really going to concentrate on. So I'm just setting the stage for where we're at with diagnosis, prognosis, and new therapies. Believe it or not, if you look at any registry, about 20% of people have an undetermined cause of kidney disease. And this is in the German kidney disease cohort study, and this is in a other registry. And it's important to realize that if you don't know why someone has kidney disease, then it's very difficult to target therapy, and hence an increasing emphasis on understanding the cause of kidney disease, not just the level of GFR and albumin, but really understanding the importance of determining cause. So we've learned, and we'll hear more later this year in other province-wide rounds, the value of biopsies. There's a kidney precision medicine project, which is looking at understanding different kinds of kidney diseases in people who have diabetes or hypertension or acute kidney injury, and that should give us insights into therapeutic targets. And studies and consortium like NEPTUNE are trying to understand from a systems biology perspective how we can use that information to inform therapeutic targets and care. And then we have increasing sophisticated techniques and learnings molecular diagnostics, deep phenotyping, and as I said before, genetics might actually help us a lot. And we're privileged now to have available in the province a kidney genetics program that's being led by Dr. Mark Elliott. So why is assessing GFR going to optimize quality of care? Well, the more accurate we can be with knowing what someone's true glomerular filtration rate is, the better it will be. And we're starting to understand and see the value of additional things, not just creatinine, to actually look at this. And cystatin C is coming, and I'll show you a slide in a moment about why that might be valuable. We're improving standardization and collaboration of measured GFR, because sometimes you really just need to measure. You can't just estimate. We have begun to demonstrate the benefit of uniform validated GFR estimating equations. There are some newer ones. They may or may not be population dependent, but how you incorporate them into clinical care is part of what we're working on. And then for us to understand the need for the more frequent use of confirmatory tests and increase in sophistication is really important. And so there's a panel of novel markers that might help us understand, much like a thyroid panel, TSH, free T4, T3. We use that to help diagnose thyroid disease. Well, at the moment, we only have a two-dimensional way to look at kidney disease. So all of these things are in the works and coming. And this is just an example of some heat map that's been looked at, looking at eGFR as measured with a more precise measurement, combining cystatin C and creatinine into the equation with 10 different outcomes. That is 6 cardiovascular, 2 kidney specific, and 2 general. So all-cause mortality, cardiovascular mortality, MI, stroke, heart failure, AFib, and peripheral artery disease, and then kidney failure replacement, acute kidney injury, and hospitalization. And importantly, these heat maps, whether you're below 65 or over 65, seem to map out very nicely and show you that increased risk by levels of GFR and urine ACR, which are important in terms of understanding our populations at risk. There are these novel biomarkers. They're coming. There's metabolomics and proteomics in blood, and metabolites and proteins in urine that people are looking at. Right now, it's still at the level of interesting science, and the prediction gains when you add these into the existing models are statistically significantly modest, but perhaps over time we'll get somewhere a little bit different. There's interesting work being done on what you can gain, information that you can gain from urine, because if you look at the cell composition in the urine as a window to the kidney, you can see markers of inflammation, damage, fibrosis, and repair. And looking with sophisticated methods like flow cytometry, you can look at T cells as markers for inflammation and tubular epithelial cells as marker for tubular damage, and putting those things together in sophisticated manners may help us understand better, instead of just looking at the urine sediment, which is what we do now. And this is nice work from Philip Engard in Berlin, looking at the ascertaining the presence of different renal and immune cells in different cases of AKI, whether it's cardiac surgery, sepsis, ECF volume contraction, diabetes, or FSGS, and looking at how these are enriched with different parts of altered and damaged cells, and perhaps we can use these eventually to differentiate disease entities. So it's a pretty exciting time to think about the other diagnostics. And then just more locally, perhaps, or something more amenable to us than flow cytometry and sophisticated methods for urine, we're looking at better imaging to inform care and guide therapy. And so MRIs we do in many places, but if you look at a multi-parametric MRI, there are many things that you can use it for with some specialized techniques to understand renal physiology. And whether that's oxygenation, microstructure, hemodynamics, that one image with enhanced with various things can actually help you to understand how well the kidney is working, and what potential sources of disease or metabolic or other processes have been impacted. And so that better imaging as a non-invasive tool might actually help us understand how the kidneys work in health and disease. And if we can then look and compare that against histology and clinical variables with some prospective data, we might be able to get somewhere quite different with this imaging technique, which is available in many places, although not all. And there are right now studies being led by Nick Selby and others looking at standardization so that when you read an MRI with these various techniques, you actually can understand what they're saying and we can compare across studies and clinically. So we've increased our understanding of relevant risk factors for outcomes. And as I said, we all know about the traditional risk factors, but there are these genetic risk factors that I mentioned, and they're not all fully penetrant, and the time frame might be long, but we are learning more and more as we go. And there are these novel risk factors that are becoming more standardized in their assays, and perhaps we'll add things like KIM1 and soluble TNF receptors. But we have to still prove that they're useful beyond the traditional markers, and as I said, perhaps not quite ready for prime time. We have made some progress in predicting the risks for clinical care and decision-making. There are many, many different risk equations. The one that most of us know, because actually BC was a part of the derivation and the validation of this kidney failure risk equation, is one, but it is important to realize there are many tools. And as we increase the sophistication and number of prediction tools, it's important to think about how we use them. So there are some for kidney donation, some to predict decline in GFR. If your GFR is greater than 60, the KFRE, as I said, now has thresholds for action, which I'll show you later in this talk. And then there are some cardiovascular disease risk predictions that add on to CKD and some newer ones. And so how you connect those risk equations and thresholds to specific recommended actions to help physicians that need still to be tested, or at least to be used in clinical care to see how well we can optimize uptake. And I thought I'd show you that this is an example of an advanced CKD risk calculator where you plug in all the different variables and you have a risk not just of kidney replacement therapy, but also cardiovascular disease and death. With all the different probabilities of what might happen to this one individual. And why that might be important is you might talk to this person differently, knowing what their risks of kidney failure versus a cardiovascular event versus dying are. And this has actually been tried now at Hopkins, and under the guidance of Morgan Grams, they've put in place this little KFRE score that pops up in their EMR that tells you, based on their last eGFR date, what their risk of kidney disease is, and then actually has this as well within the marker that shows you the changes over time, over a large period of time, and what those risks are of various things, where kidney failure is a lower risk in this person than having a cardiovascular event. And so think about how we might begin to use this and in our current thing for both decision-making, referral, and other thresholds. So we can better tailor treatment plans if we have these improved prediction tools. We make sure that the right therapies are given to the people that will benefit the most if you have limited resources. We can probably improve patient counseling a lot and the timeliness of decision-making. And I won't show you this here, but there's some lovely work that's been done in BC by Dr. Iktikasman looking at how we might change the way that we plan vascular access based on some of these tools, and perhaps how we might refer for even modality education. But importantly, we could also design better clinical trials by targeting the specific populations and phenotypes and those at highest risk. And then we could also target processes of outcomes, knowing if we want to have cardiovascular disease as our outcome or kidney disease or the composite. So in 2017, we developed a roadmap for how we would close the gap in care research and policy with a group of international experts in all kinds of areas in kidney disease, including policymakers and industry, and above and beyond improving the identification and reducing risk factors, including acute kidney injury, which we're also working on this province under the guidance of Dr. Burks and many others. We're also going to improve understanding of causes and consequences, but our big push is to develop and test new therapeutic strategies. And I think that has come to a bit of fruition lately. And so now we really do have a changing landscape in nephrology. And I think that's very exciting for all of us, as I said. So there are evolving therapeutic options now. And after a huge gap in anything exciting, there's now a series of very exciting trials and using different different agents above and beyond ACEs and ARBs, but including endothelial receptor antagonists, SGLT2s, mineralocorticoid receptor antagonists, and GLP-1 receptor agonists that are very exciting. And I'm going to speak for the rest of this a little about those things, because I think that's what the patients are excited about, and we as healthcare providers should be excited about. A step back just to remind people that chronic kidney disease progression is driven by the combined effects of metabolic, hemodynamic, inflammatory, and fibrotic factors, all of which also impact cardiovascular disease, because we live in one body and all of these things are actually important. And all of this damage that we see to the kidneys is driven by these three or four, depending on how you count, processes, if you will. You've all heard about the SGL, so we target those processes now with some of these medications. You've all heard of the SGLT2 inhibitor trial, so I will not spend a lot of time, but as far back as 2015, when EMPA-REG came out and we saw an effect on kidneys, there's been a plethora of studies looking at either isolated kidney disease and diabetes, heart disease, combinations of kidney and heart disease with and without diabetes, and all culminating in the most recent November 22 study, which is now a year and a bit ago, EMPA-Kidney. But what happened is, recognizing the importance of the totality of knowledge, a large consortium called SMART-C came together, looking at an individual level meta-analysis that combined all the large trials of SGLT2 across populations, be they diabetic, cardiovascular disease, or kidney disease, that all had measures of GFR and urine ACR, and all had concordant outcome measures of cardiac and kidney events. And so these 13 trials that are listed here in terms of their main focus of population, with a range of GFRs, a range of follow-up, and about 18% without diabetes, gave us 90,000 people in whom we could look at important outcomes. And I'm just going to remind us that when you look at the totality of the data, whether you have diabetes or not, the SGLT2s are significantly better than placebo or anything else. They prevent acute kidney injury, which is really important because we know that to be a driver of either chronic kidney disease or acceleration and change in the trajectory of kidney disease. And importantly, from a patient perspective and a healthcare system perspective, it also reduces cardiovascular death or hospitalization for heart failure, which, as you know, plagues many of our patients. And when they put all that information together, when you look at people with diabetes or without diabetes, and you look at the absolute effect, so these are all relative changes that I showed you before, that there are a substantial number of reduction in kidney disease progression, acute kidney injury, cardiovascular death and hospitalization for heart failure. And in those without diabetes, no safety signal at all. And those with diabetes who are prone to other things, ketoacidosis, and perhaps a signal for lower limb amputation, which is likely driven by one study and thought to be not particularly germane to the class. And so if you look at what SGLT2s might do in terms of delaying progression of kidney disease, if you start at a higher GFR and reduce it, as you see here, you might actually buy this 63-year-old person with relatively well-preserved GFR 15 years. Now that might be attenuated if you start with a lower GFR, but we're trying to develop these curves for different groups of people so that we can really understand whether or not we can use these to really mitigate the need for dialysis and transplantation. And so after SGLT2s, we've also begun to understand the importance of the role of aldosterone in disease progression as a pro-fibrotic drug. Aldosterone, along with cortisol and other radical oxygen species, actually bind to the mineralocorticoid receptor and create a number of different downstream effects, including endothelial cell dysfunction, fibrosis in the heart and the kidney, a number of electrolyte imbalances, as well as vasoconstriction and fibrosis, and probably also impact the brain. So there's a lot of cardiac and kidney effects of having aldosterone excess. And that's been capitalized on by looking at some of the familiar methods that we use to target the renin-angiotensin-aldosterone system. So you're all familiar with ramipril, losartan, and irbesartan. These impact here. But as well, we have spironolactone and finerenone, which I'll talk about. And then I'll also talk about what we can do to inhibit aldosterone. So the non-steroidal MRAs, finerenone, versus the steroidal MRAs, is an also exciting new progress in the field. We know that finerenone now available is actually a very different mineralocorticoid receptor antagonist, both structurally as well as its side effect profile and tissue distribution, and so was thought to be a much better alternative to what we usually use with spironolactone. And finerenone has been studied now across a spectrum of chronic kidney disease and type 2 diabetes. And so here is the heat map with a review of all of the different groups in whom it's been studied, but not in people with HFrEF. And in Fidelio and Figaro, and I know many of you have seen this data, but I thought it's always worthwhile to summarize. We looked at the spectrum of kidney disease, so stage 1 and 2 in Figaro with heart disease, and stage 3 and 4 in Fidelio, all with diabetes, with different endpoints. One was a kidney endpoint, one was a heart endpoint, and each of them had the mirror image secondary endpoint of heart versus kidney. And both trials showed that it was well tolerated, and there was a small increase in incidence of hyperkalemia, but a very minimal impact in all of the studies. And those were pooled into the fidelity analysis. And you could see that there was a modest impact on systolic blood pressure. Importantly, as a little caveat, the higher blood pressure, the more impact on blood pressure there was. So not to forget that this might be something worth remembering. There's no effect on hypoglycemia. There are no sexual side effects. And yes, there was increased hyperkalemia, but that did not lead to any major changes in clinical care, with very minimal discontinuation of the drug because of that. And then if you look at the combined fidelity with cardiovascular endpoints, kidney endpoints, or all-cause death, you'll see that it, for the most part, with and without SGLT2 use, was of value. And importantly, perhaps that value is greater when you use an SGLT2. And so there's this new paradigm for kidney care to prevent progression of both kidney and heart disease using ACEs and ARBs, SGLT2s, and now non-steroidal MRAs. But there are some other agents, aldosterone synthase inhibitors, GLP-1 receptor agonists, and ERAs. And where do they all fit in this mishmash of how we're going to try and address inflammation, hemodynamic, and metabolic changes, all of which interact to cause progression of kidney disease? So that slide that I showed you before, you're familiar with the RAS and it's the things that I showed you before with respect to different drugs, but now we also have aldosterone synthase inhibitors. So imagine these to aldosterone as ramipril is to angiotensin 1. So we have these things that block the way that ARBs block, but now we have the ASIs that actually are like a sister companion to the ACE inhibitors. And so this is slides that I was able to get from Kidney Week from Catherine Tuttle. For those of you that were not there, this was a phase 2 clinical trial looking at an aldosterone synthase inhibitor in a CKD. And I'm not going to go through all the details. Basically, there were people that were not on empagliflozin and those on empagliflozin, and trial of different doses of this ASI with matching placebos in different groups, and followed for a period of time over about 14 weeks, looking at changes in urine ACR as well as the major outcome, because that's been shown in many studies to be a very good prophecy for the for progression of kidney disease in this group of patients. And again, there was the majority of them were diabetic, although not all, which was really important. The GFRs are reasonably well preserved. The urine ACRs are quite high. And so this is certainly a high risk group. And in that group, whether you had empagliflozin in the background, if you had empagliflozin in the background and SGLT2, you certainly could see by dose an improvement in urine ACR. And I think that's important. And it didn't seem to be that there was any difference between the 10 and the 20. So that was important. This is the same data shown in a bar graph. The strongest urine ACR response was observed with the combination of an AESI and empagliflozin. This is a graph showing the proportion of patients that had the desired response of less than 30% by dose. And that's without, and this is with empagliflozin. So you can see that this 10 milligram dose with EMPA gives you the greatest reduction in urine ACR. And they had additional endpoints which were exploratory because it's a small study and short duration, but there were effects on eGFR irrespective of whether you had empagliflozin in the background, which is really important. And there were also important changes in systolic blood pressure, which I think is worthwhile noting, up to as much as 8 millimeters of mercury. And it was a safe drug because although, yes, there was some hyperkalemia, there was no discontinuation rate that was different than any other study, but was not it was similar to other studies, including the Fidelio and Fidelity study that it showed you, and there were no fatal hyperkalemia events. I'm not showing you all the data from here because I really just want to make the point that this selective aldosterone synthase inhibitor, which I will now call ASIs, dose-dependently reduced albuminuria in people who had established kidney disease. And they occurred, those reductions occurred with or without concurrent SGLT2 inhibition, and it's generally well tolerated with slight increases in potassium. And so the really exciting part is we now have a trial that's going to be launched in BC and Canada and actually internationally called Easy Kidney. And that's going to be done in the first half of 2024. And we're hoping to get as many BC sites as possible. So we have this larger trial that will definitively assess the safety and efficacy of targeting this pathway in addition to the others in a broader range of people with kidney disease, non-diabetics and those with lower levels of albumin. And there's some question about whether or not we might let people in and demonstrate safety of accepting potassiums that are a little higher. And this study is going to be the biggest ever kidney study, 11,000 patients in a randomized controlled trial comparing SGLT2 with or without an ASI in people with kidney disease. So stay tuned for that. So what else is there? Well, let me talk a little bit about the GLP-1 receptor antagonist. Whoops, what happened? So GLP-1 agonists are not just for diabetes and weight loss. That's what all of you know Ozempic or semaglutide as. But there's a mechanism of action by which these agents might actually provide a kidney benefit. It's not that well understood, but it's likely, like all drugs nowadays, a combination of both direct and indirect effects. So yes, it impacts glycemic control. It reduces blood pressure and weight loss. Those are indirect. And what it does on the kidney is it induces a natriuresis. It changes the hemodynamics, improves endothelial function, has some anti-inflammatory properties, and also inhibits that RAS system that we just finished talking about. And in a number of diabetic studies, semaglutide consistently reduced the risk of major adverse cardiac events in people at different levels of GFR and urine ACR, as you can see in this slide. They show a consistent benefit, kidney benefit in all of the cardiovascular outcome trials, and I've listed them here so you can see that they're favored. And the reduction, as I said before, is associated with reduction of urine ACR, is always associated with reduction of kidney and cardiovascular disease in people with type 2 diabetes. And so hence the reason that we try and address this in an ongoing way. In Fidelity, they explored those people on GLP-1s and the MRA combination and showed, as you might expect, a greater reduction in urine ACR. And when one looked in the decrease trial, in GLP-1 and SGLT2 combination, it also reduced urine ACR than any albuminuria than either one alone. So a lot of data to suggest the value of this medication. And then, of course, if you look at SUSTAIN and PIONEER, the change in GFR over baseline is improve with semaglutide, including the change in the annual eGFR slope. So these are all really positive things, but not in studies that were ever designed to look at a kidney outcome. And so FLOW was that study. So FLOW was designed to look at 3,500 people with type 2 diabetes, reasonably controlled hemoglobin A1C, and you see all the inclusion criteria here. They were all on a RAS blocker. They're randomized to once a week semaglutide versus placebo with standard of care. The population is here, and these are the outcomes of greater than 50% reduction in GFR compared with baseline, or crossing the threshold to less than 15, or cardiovascular renal death. So almost 2/3 of the FLOW trial population were at very high risk, according to that heat map that I showed you before. And as you know, it was stopped early due to efficacy. And we'll soon hear the results, likely in the first half of 2024, probably at the ERA, but we're not sure. And so I think it's very exciting that this is another drug that, when looked at specifically for kidney outcomes, appears to be beneficial. And to better understand how it works, there's a number of studies that are going on. ReModel is a smaller study looking at the renal mode of action, and they're going to look at a number of different things that you've heard me talk about: kidney biopsies and multiparametric MRI, as well as some different urinalyses and biomarkers in blood and urine, and look at the change in endpoints to see if we can understand at a molecular level how this works. And SMART is a study looking at obese individuals without diabetes, and all the same methodology to really understand in smaller groups of people targeted, how is this drug working, so that we actually get the right person on the right drug at the right time. And so the key message from this part is that FLOW is the first kidney-specific outcome trials. It's conducted in about 68% of people. They were at high risk, and only about 15% were already using SGLT2s, and it really is a promising new class coming soon, but not yet ready for prime time. So could there possibly be more, you ask? Because it's, well, there is. So endothelin receptor antagonist is the next new frontier, adding to our armamentarium. I won't go through this in detail, but endothelin and endothelin is an endothelial dysfunction, contributes, as I showed you in earlier slides, to cardiorenal risk in people with kidney disease. And it's through that endothelial T1 and T2 receptors that this occurs. There are impacts on the vasculature, the podocyte, the tubule, mesangium, and inflammatory cells, never mind what it does to other vascular cells in the rest of the body and in the heart. But that being said, there have been a number of studies looking at these endothelial antagonist trials, the ERAs. They all have fancy names: avastatin, atrasentan, and zibosentan. And then there's the sparsentan irbesartan combination. These are the names of the studies. You can see that in 2023, we were rich with various studies looking at specific diseases, IgA and FSGS, and Zenith, which was in proteinuric CKD, which is what I'll talk about just very briefly. So Zenith is a combination, was specifically looked at in combination with SGLT2s because of the fear of earlier ERA studies of fluid retention and heart failure. And it was thought that with the combination, you might actually attenuate that. And so the hypothesis was that if you combine zibosentan and dapagliflozin versus dapagliflozin and placebo, you would actually have an impact on albuminuria and fluid retention, and then select. This was an attempt to select the right dose for future trials. So this is 18 countries with 160 sites and 447 participants. So that's a pretty big study for something like this. And the primary endpoints were in fact very encouraging, with the fact that you could get a reduction in the mean change in urine ACR with the combination. And that significant increase was seen with the 1.5 arm and also in the 0.25 arm relative to placebo, but greater in the 1.5 milligram. And so irrespective of diabetes status or blood pressure, the combination seems to delay/reduce proteinuria, whether you were diabetic or not, irrespective of your GFR and irrespective of your baseline blood pressure. which I think is quite exciting if one thinks about it. So what are the next steps with the ERAs? Well, those reduction of albuminuria in a relatively short-term study is not going to make people jump onto that bandwagon. So now there are a number of larger trials, some of which are also coming to Canada and BC, looking at heart outcomes and changes in eGFR, again, for a slightly different population, because there are some people who will be excluded from using these drugs if they do have a history of heart failure, etc. So where does that leave us with care, guidelines, and research? That was a bit of a whirlwind tour through what's new and what's happening, but I hope it gives you a feel for how exciting it is in the kidney world right now, with all the different drugs available. And relative to cancer drugs, which are $3,000 a dose or $100,000 a dose, these drugs, even at their list price, are maybe at the most $1,000 a year. And, you know, as we know, all those prices come down over time. So we're talking, relatively speaking, not expensive drugs in the greater scheme of conditions. So as many of you know, the KDIGO clinical practice guidelines will be available in print and online early in 2024. And again, I had the privilege of co-chairing with Paul Stevens, this group and a group of really thoughtful people. And so the format for the guidelines is a little bit of what I've already told you about, which is global health burden, the evolution, and then some specific considerations for young, old, sex and gender differences, and updating the heat map. And then there are a number of different chapters and sections. But I want to draw our attention that we really do need to consider CKD across the lifespan. Remember that people are not static in time. They age, they go through different hormonal surges. Sex and gender impact both behavior as well as biology, and the multidimensionality of chronic conditions as one ages can really impact care. So we need to have a very individual focused method of applying the guidelines, and that's what we've tried to iterate within all of the different programs. So with respect to diagnosis and evaluation, we're really stressing that really understanding why your patient has kidney disease is really important. And we now have, and we need to know that from a number of, we can gather that information from a number of different sources and laboratory tests that are becoming more and more available, but really important to think about, do you really understand why this person has kidney disease? And then how you evaluate kidney disease is you select the right tools for the situation. You need to know, when you do that creatinine-based eGFR, what are the sources of error? Do you need a more accurate GFR? And if you do, then we're soon going to have available the ability to measure cystatin C. And if you think that might not be good because there's something else different about this patient, then you measure GFR. And it's really important that we think through our patients to get the best, most accurate diagnosis of their kidney function, because that might impact drug dosing, especially those drugs with a very narrow therapeutic window. It may impact living donor assessment, your cardiovascular other risk assessment, how we counsel people, and how we make decisions. And there's work going on now to see how using these different equations or measurements might impact the way that we talk to people. So we also have encouraged practitioners to have a clear understanding of the value and limitations of GFR, understand creatinine and cystatin C, and then think about the same thing when you look at measurements over time and what could be the sources of that variability. It might be a different lab, it might be a different assay, it might be other things. We actually encourage people to measure GFR and understand how best to do that, because there are places and times where you really want the most accurate GFR possible, not the estimate. We understand that the heat map is for populations, it's not for individuals. And individual patients have a wide range of actual risks. And as a very patient-centered community, we want to understand individual risks for each outcome that's very much impacted by their own characteristics, comorbid conditions, and lifestyle. And the heat map is about population risk relative to non-CKD. So you really do need to calculate the individual risks. And so that's what we're actually saying, is that after you stage according to GFR and urine ACR, establish the cause, you then have to estimate the risk of progression and initiate treatments or discussions as appropriate. we're recommending externally validated equations to look at the absolute risk for kidney failure. And there are thresholds that have been suggested in multiple studies that could be used to look at the timing of care, the timing of determining the modality education and preparation, including vascular access and referral to transplantation. We also know that there are very disease-specific prediction equations for those with IgA nephropathy, for example, and ADPKD. And so don't get fooled into using KFRE for everybody, because it doesn't work in everybody for what you want it to. This is just a reminder that the KFRE does better than physicians in terms of accuracy of predicting time to kidney failure. So this is a nice study that we're attempting to replicate in a number of other places. And that for cardiovascular risk prediction, there's the CKD patch score from 2020, which is added on to current score tools. But there's a recent statement by AHA looking at novel prediction for MI and heart failure, which might, again, be very important in terms of conversations with patients. And there are mortality risk predictions as well. All of these to help us help both the patients, families, and healthcare systems provide the appropriate types of care at the right time. Chapter 3 looks at delaying progression, and I basically spent most of this morning telling you all the different wonderful ways, but what I didn't talk about was the very important component of healthy diet and weight management, and the regular risk factor assessment every 3 to 6 months. Later in the year, there'll be province-wide rounds on the new things that we're learning in terms of dietary modifications. First-line therapies now are SGLT2, low blood pressure, and statin if you have high risk, and then using other medications. And of course, this would need to be updated as some of the data that I just showed you comes into mainstream. And so there will be a much faster update of these guidelines. There's emphasis on really attending to dose interactions in deprescribing, and importantly, not to stop drugs forever, to actually assess what the right dose is and what interactions there are. We're fortunate to have many pharmacists helping us do this, but where you don't, then that becomes healthcare professionals in other fields to really pay attention to this, so we optimize the medication impact and minimize medication-related problems. We were a bit shocked to find out that there's actually limited data to inform our famous sick day rules, and there's evidence of harm due to non-restarting of important meds. So the important thing from this practice point is that when you do stop a drug because of very real reasons, that you're afraid of hypotension, et cetera, they have a dehydrating illness, that you should communicate a clear plan of when to restart those discontinued medication to both the person, the healthcare professionals, and ensure that that's documented in the medical record, because that's the way that we actually don't harm people, because we don't give them back the medicines that they needed before they got sick. There's a chapter on optimal models of care, and this audience is well versed in the role of education, navigation, surveillance, and management as the cornerstones of the way that we help to manage with wraparound care our patient groups. And importantly, to use validated tools where available to identify and assess symptoms. And this is a nice graphic showing the prevalence and severity score of the different symptoms that are common in our populations, irrespective of age. And then to manage common symptoms, and that in people with lower levels of GFR or poor growth in pediatrics or the elderly, be very attentive to things like involuntary weight loss, frailty, and poor appetite, using, again, validated tools if they exist. So what I've tried to do in the last 40 minutes is give us some excitement about what's coming in terms of better diagnostics that inform care, study design, and direct therapeutics. That there are so many new drugs available with solid evidence to delay progression of kidney disease, and there are ongoing trials with new agents and repurposed, if you will, agents that weren't designed for delaying progression of kidney disease, but seem to, that add all these additional tools to our armamentarium. And so just to summarize, I started with the context of kidney disease as a public health burden and reminded us that delaying progression impacts the greatest number of people at much lower cost than anything else we can offer. That we have these better tools and all this data. There are guidelines coming, and I think that the best strategy for us and our patients in 2024 is to implement the evidence-informed care, including tools for diagnosis and prediction, and where possible, participate in ongoing trials. And so with that, I'm very happy to stop sharing, if I can. And we have a few minutes for questions, and I hope that that was a productive way to start the year, if that's okay with everybody. So I'm going to start with some of the questions. So can cystatin C be ordered on a regular life labs? Not yet, Julie, but we are working with our biochemistry and medical biochemistry group and the BC Lab Physicians group to get cystatin C more available. It can be ordered as a special out of province. It's OOP. It gets sent out. It is valuable for those people in whom you really think that there's something discordant, but we're working on getting it more available in BC locally. So that's a great question. But if you think it's really important, it is orderable, and I myself have done it. I know a number of others have. Children's Hospital does it a lot because children's creatinines are often much more susceptible to other things, and so you really need a better assessment. Dr. Elliott's asking, well, given the proliferation of medications available at delayed progression, each with slightly different inclusion criteria, is there a role for tool to help non-nephrologists optimize where the time on therapy could be maximized? Yeah, that's a great question. I think that instead of this GDMT, goal-directed medication therapy, where everybody gets everything all at once, I'm not so sure that we shouldn't profile people. So I think there's starting to be this, well, if you're overweight or obese, then maybe a GLP and have kidney disease, maybe a GLP-1 is your best first drug. There's not a tool yet, but I think part of using more regularly all the different prediction tools that do exist is it might begin to help us look, and that might be something with AI and other things that we could say how many people should be on drug X versus drug Y. I think that upstream is what you're talking about, and I think there's certainly huge value. Most of those studies, as you know, had a GFR above 45. Those are not necessarily people we're seeing. So it would be important. But at the moment, if we don't start to use those drugs, nor will the non-nephrologists. So I think we probably have to start and then help them to use it. So good question. I'm very insufficient answer on my part, sorry. Another question. So many patients are on Ozempic now, but most people tell me after starting they have no appetite, total loss of enjoyment of eating. Is losing 8 pounds really worse? So that's also a great question. And I think that's part of what the flow study might help us understand. So it got stopped because the endpoints were good, but I don't know what the patient satisfaction, which would have been a secondary outcome, was actually doing. And I think we need to think about, it might not be for everybody, and it may be that different people tolerate that loss of appetite differently, and it is worth it for them to delay progression of kidney disease. So again, a good question, and again, that the need for us to individualize care and not just use something because it works in a whole bunch of people, it's going to be really important. So as nephrology professionals, we've always been commended for our thoughtfulness and our precision. So maybe we need to be a little bit more precise about who gets what, and also ask these very important questions about what is worth it. And it may be that you don't need that high a dose, or you might need, there may be the wider time interval. That giving it twice a week gives you every 2 weeks gives you as good effect as once a week, and maybe that reduces some of those loss of appetite. So really good question. Carolyn, could such a tool exist for our own prescribing community, perhaps with coverage information, as this is all changing so quickly? Great question. We're working on getting the KFRE into trauma so that when you you could at least see for some purposes what your greatest risk is. That's one. But, you know, I think with AI and other things, that maybe we can get there. That it's going to require a fair amount of sophistication, but perhaps. I think others are also working on this. The coverage information, I think we're hoping that, you know, with the proper economic arguments, we might be able to get somewhere different and get more things covered for our patients who are at highest risk. I think it's a little bit harder with people at lower risk for us to be the advocates for all of that, which is a shame because to Mark's point, you want it done early on, but we'll work on it. Other questions, either raise your hand or otherwise? I think we had a number of people from international sources on the call today, so thank you for joining. I think it's late in the day for some of you. But yeah, thank you very much for listening. I hope it wasn't too much, but I think it's so exciting. It was hard for me to figure out what to cut out when I was trying to put this together for you. So stay tuned. Some of these themes will be amplified in some of the talks coming up for the rest of the year, and wishing you all a really wonderful rest 2024. And thank you again all for coming.